So, guys, it's 5 past. Do you think it's a good time to start? I think whoever comes, we'll go through introductory stuff a bit first. Okay, so since quite a lot of you were in the older years, we decided with Georgina to add another separate part, including inflammatory conditions as well as some extra conditions that show up in an ECG, just as a bonus, which will only take 5 extra minutes of the lecture time, but can make the difference, especially if you know it during the course of an exam. I hope you don't mind. Keep in mind that we stick to our basic principle, and today we will talk about ventricular arrhythmias, heart blocks, as well as STEMI and non-STEMI myocardial infarctions and how they appear in the EKG. We also keep in mind, and I remind you, that books are always the basic step towards mastering ECG, and this lecture, even though it is helpful, I guarantee you will make a lot more sense if you use a book along with it. Also, the study material with a strong medicine ECG course, especially for 4th, 5th, 6th year students, will be of great help in order to master this trick once and for all, and I think it will be much easier once you get the basic grasp of it, okay? Any questions? Okay. Let's see. Since we're all here, I think I will start. So today we will start our lecture with ventricular arrhythmias. I think you'll remember what arrhythmia was a problem in the normal functioning of the cardiac cycle and the impulse of the message, and it's anything that originates below the bundle of His. So by now you should all be aware that anything that occurs due to a problem in the ventricles will present in an ECG with an aberrant QRS, since we said that the QRS represents the ventricular depolarization. And it is true that there is a possibility that the P wave will be hidden due to the abnormalities that occur in the QRS. Now, I hope you all remember what extrasystoles were. Does anybody not remember what extrasystoles were from Monday? Anyone? If you don't remember, it's okay. We can talk about it now really quickly before we start. Okay, I take that as a yes.
I think it's
so. Tell me.
It's a premature contraction.
Yeah. Okay. So you're correct. It is a premature contraction, and ventricular ones are the ones that originate in the ventricular myocardium, as the name would suggest, obviously. The main differentiating factor between those and the atrial premature contractions is that the formation of the QRS is extremely different, and there is complete compensatory pause. And you can see it right here that the time in between the extrasystole and the next beat is equal to the time that is taken from a normal beat towards the next. Do we all remember that? Do we remember how the compensatory pause works? I guess so. It is present in the lecture, and we can go through it if you'd like. Now, why do we care so much about ventricular extrasystoles? Because, as you can see, it's completely aberrant QRS, and it's actually very important for your clinical practice. Ventricular extrasystoles can actually initiate ventricular tachycardia or other ventricular arrhythmias that are very dangerous for the life of the patient. Okay, so ventricular extrasystole includes an aberrant QRS with a complete compensatory pause, and most of the times the P wave is absent before the QRS. Now, we will classify them based on the relationship with normal beats that occur between the extrasystoles. Okay. So, as you can see here, let's talk about Trigeminy. Trigeminy is a condition where every normal cardiac cycle, so a P wave with a QRS and an ST segment and a T wave, will be followed by one ventricular extrasystole, which will then be followed by a normal cardiac cycle. Does this make sense? So it's one extrasystole, one normal cycle, one extrasystole. This is called bigeminy. Bigeminy, so every second, okay? Now, trigeminy will be when there are two normal beats between every extrasystole. So we'll have an extrasystole, two normal cardiac cycles, an extrasystole, and so on and so forth, okay? Keep in mind that if there are more than three extrasystoles occurring one after the other, we will then begin to talk about paroxysmal ventricular tachycardia. Does this make sense? I need you to cooperate with me in the chat today and tell me yes, because we will talk about a lot of terms and it's very important to keep track. So bigeminy will include one normal beat followed by an extrasystole, followed by a normal beat, followed by an extrasystole. And trigeminy, it's when you have two normal beats between the extrasystole. Of course, we understand that is ventricular because of the aberrant QRS and the presence of complete compensatory pause after the end of the extrasystole. Now, I'd like you to keep this slide in mind and we will come back to it again later. But as you know, we have two ventricles and you can be asked to designate which ventricle the extrasystole comes from. And the trick here is very simple. If you are familiar with right and left bundle branch blocks, you will know that the morphology of the QRS differs depending on the presence of right or left bundle branch block. To know where the extrasystole is coming from, you need to think of the morphology of the QRS. If the QRS looks like a right bundle branch block QRS, then the origin of the extrasystole is in the left ventricle. And why is that? Because if you think about it, it looks like the ventricle is firing at a completely wrong rate, like the other part of the half is broken, hence the opposite pattern. So if the QRS looks like there is left bundle branch block, then the origin of the extrasystole is in the right ventricle. I keep this in mind and then we'll come back to it when we talk about bundle branch blocks of Tavara, okay? So, ventricular tachycardia. We said that tachycardia means that there is a pace that's more than 100. It's true that the ventricles are firing between 120 and 200 beats per minute. It's ventricular, so it is logical that the morphology of the QRS will be aberrant, okay? And usually they initiate from the presence of three or more premature contractions, so three extrasystoles, and then we carry on firing at a very fast pace, causing ventricular tachycardia. The nice thing about the ventricular tachycardia is that we can classify it based on the symptomatology, the duration, or the shape. If the QRS shape that occurs in the tachycardia is constant, so every QRS looks the same at the rate of 120 to 200, then we have monomorphic ventricular tachycardia. Polymorphic will be when you have multiple variants of the QRS appearing in the tachycardic strip of ECG, okay? Now, based on duration, it can either be sustained or not sustained. Not sustained means that it lasts less than 30 seconds, and this is very important mostly for clinical practice because there is exhaustion of the heart and the patient becomes hemodynamically unstable. So then you have to take severe action and fast. And last but not least, the ventricular tachycardia can be pulseless or with pulse, and pulseless will obviously be associated to not sustained because there is hemodynamic collapse and there is no sufficient amount of blood reaching the periphery. I think this is all very logical. Let's talk about monomorphic versus polymorphic, and this is the part where I need you to understand. Monomorphic means all the QRSs look the same, and polymorphic means there is an abundance of QRS shapes. As you can see, monomorphic occurs in the setting of a healed infarction, while polymorphic will occur during active infarction, acute coronary ischemia, or prolonged QT interval due to hypokalemia, hyperkalemia, hypomagnesemia, and medications such as MUDr. They will all cause prolonged QT interval, also known as long QT syndrome, okay? Now, let's go. And does anybody want to go through this ECG with me? Feel free to pick up the mic. Anyone? Hi, anyone? No? So the concept always remains the same. This rhythm, is it regular or regular? Just type in the
Regular?
It is regular, yes, of course. And the rate using the rule of 300 is how much? Approximately. Approximately is fine. Would you?
Maybe like 250, 300?
Yeah, something like that. Yeah, more like 200, okay? More like 200. And what do you see? What morphology in this strip is not of the usual type? Because we talked about multiple types of tachycardia and multiple types of formation, but what is the problem here? Is it the P wave? Is it the T wave? Is it the QRS? What is the problem here?
You can see the P wave, but there's RSR prime in V1 and V2, so it looks like right bundle branch block. So the origin.
It is, no, I want you to tell me that it's ventricular because there's a problem with the QRS, and we will go through, because you need to understand the origin. You understand the origin. There is right bundle branch block morphology. So can you tell me which ventricle it comes from?
From the left ventricle?
Yeah, from the left ventricle. This is actually the toughest theoretical question you can get at an ECG in a state exam of internal medicine. Now, polymorphic ventricular tachycardia, I think one familiarize yourself with this shape here. I'm guessing this is an album that many of you have actually heard. This is an album of music. I'm sure most of you know it. Will be familiar and recognizing polymorphic ventricular tachycardia. This is also known as torsade de pointes. And it's very much related to an, metabolic abnormalities. Again, this is irregular with multiple variants of a QRS. And as you can see, they are completely aberrant. Was it Nikita that told me the origin of the previous exercise?
It was me, Jan.
Who are you?
Jan.
Who are you? Okay, so would you care to tell me which pattern do you see here? Which pattern of bundle branch block? Because I take it you understood the other one. So if we say right here or here or here, this is indication of which bundle branch, left or right? This is a bit of a tough one, but you can see here, it's like a continuous doubled headed ECG. This will actually be left bundle branch morphology. So this is from the right ventricle. This is a bit tough, but we'll go through it later, okay? Is everyone familiar with ventricular tachycardia? Does anybody have any questions? Now would be a good time to ask. Everyone familiar? Good. Okay, now, ventricular flutter. So we remember we talked about Adrenal Flutter, and the theory behind it, it's not much different in ventricular flutter. So we have an aberrant ECG. It looks like sinusoids, and you can see it here. I think it's pretty clear. And this is equally an event that is provoked by a ventricular ectopic beat. So we will have a ventricular extrasystole, and this will lead to a sinusoid-like pattern of the ECG, which we will call ventricular flutter. Okay, it will fire at a rate of 180 to 200, and I think you can also see this here. And that's it. It's pretty straightforward as an idea. Okay, does everybody get ventricular flutter? Good. Now, let's talk about ventricular fibrillation. And this is a very important rhythm because the heart rhythm is completely irregular as well as the activity. And you see that it fires at a colossal rate of 350 to 600. And why do we care about this so much? Because this means that death is upon us, okay? So a patient having this, actually, tell me, is this rhythm a shockable one? The ones that have passed first aid. Ventricular fibrillation, is it shockable or non-shockable rhythm? Do we use electricity to return the patient back to normal rhythm?
Shockable.
It is shockable, yes, it is shockable. This is why we care, okay? And it's also very good to think about the reversible causes that may cause this event to happen. We think of the 4H and the 4Ts. It's very important for 5th and 6th year students. Hypoxia, hypothermia, hypovolemia, and metabolic disturbances such as hyperkalemia, they all cause ventricular fibrillation, same as toxins, drugs such as digitalis, tamponade, thromboembolic events, or rotation pneumothorax, they all cause ventricular fibrillation. And you can see here that it is exactly the same as atrial fibrillation. There is no proper formation of waves that correspond to the ventricular depolarization. Does this make sense? It fires at random at a very fast rate that the computer cannot cope in writing on the paper at the correct rate. So now you will say this completely looks like polymorphic ventricular tachycardia. And this is true. It does look like polymorphic ventricular tachycardia. And there's a very simple trick to differentiate the one or the other. And I really want the older guys to pay attention here, because in order to differentiate polymorphic ventricular tachycardia from ventricular fibrillation, there's one question you need to ask. And the question is the patient conscious? If the patient is conscious, then it's ventricular tachycardia. If the patient is unconscious, we said that it is a pre-terminal event, and that means that it is ventricular fibrillation. Is that simple enough, or is there something else you would like me to explain about this? Philippa?
Yes, it's understood.
Okay, so this is a bit more specialized, but I find it interesting. That's why I included it in this part of the lecture. The Bruggada Syndrome, it's an inherited loss of the sodium channel functions that leads to idiopathic ventricular fibrillation. And this is from young people all the way to older guys. So it may present with sudden death in the sleep, with syncope, or it can be found at random on an ECG strip if you're lucky. And what you need to see in an ECG to diagnose Bruggada syndrome, because it's a clinical, it's an ECG strip diagnosis, is prolonged PR intervals with right bundle branch block associated with elevation of the ST in V1, V2, and V3. Okay, I'm going through this really fast because this is very rare for you to be asked, but it's actually true, especially in countries like Greece, that actually patients do have it and you do see it in practice. And I'm supposing that in Italy or Portugal, it will probably be the same. Everything clear with ventricular arrhythmias? Any questions? The silence is great. So now this is most important and it affects way more students than ventricular arrhythmias, and we will talk about heart blocks. Okay. Now, we spoke about the heart conducting system and how it operates with the sinus node and the atrioventricular node, and how there's the junctional rhythm if the sinus doesn't work properly. We talked about the anatomy, okay? Hope you all remember, you didn't forget. And the principle of automaticity. Keep this in mind, that automaticity is the ability of the heart to initiate electrical impulses without any exogenous irritants, okay? So sinus is here. Can someone from the younger guys tell me what we need in order to have a sinus rhythm? Please.
A sinus node?
Yep. You need what in an ECG to have a sinus tachycardia or a sinus bradycardia? You need, yes, a positive P wave, which is where? Yes. And yes, excellent. A P wave, which is positive in front of a QRS. This is what you need to have sinus rhythm, okay? Now, when we talk about branches and blocks, it means that there is a stop, a cut, either anatomical or surgical or a malfunction in a part of the conducting system. So this means that the heart's other nodes will take over and start replacing the sinus mode function, okay? Now, there are multiple variants, and every block is named by the part of the conduction system. So we have sinoatrial block with 3 degrees, AV block with 3 degrees, and block of Tavara bundle branch, which is right and left. And actually those blocks can be complete or incomplete, but I really think that incomplete blocks are beyond the scope of this lecture. So if you want, we can do it at a later lecture and keep it to the basics here, if that's okay. Now, sinoatrial block. We will separate it into degree and keep in mind that the smaller degree, the less severe. The highest degree, the more severe, okay? Now, the first degree SA block is when we have conduction of the impulses from the sinus node to atria being slightly prolonged, but so little so that you cannot actually detect it in an ECG, okay? Does this make sense? So it exists as an entity and we care about it because this usually progresses to second degree and third degree, okay? So I need your guys' attention here because we will talk about a phenomenon called Weichenbach periodicity. And I know that the pathophysiology department really likes this term. Weichenbach periodicity, or maybe let's talk about periodicity first. Periodicity is something that happens in constant intervals, okay? So it's like the opposite of frequency. Is everybody with me? Now, in second degree SA block type 1, you will see here that this is where the node fired. This is where the node fired, but the interval from P to P, let me draw it actually. As you can see here, this interval, can you see it? It's not this interval here, is less long than this one. And what happens? This interval will continue to progressively get longer and longer up until the point where, as you can see here, a cycle is missing. And this will happen at a fixed rate. This is why we call it Weichenbach periodicity, because it will prolong, and then not show up. Does everybody understand this?
Yes.
We will talk about this 2 or 3 times today, so it has to be pretty clear from the get-go. Okay? So.
Yes.
Good. Again, the mouse doesn't want to play. So gradual prolongation, and then you stop having a cycle. Now, this was with Weichenbach phenomena. Okay. Now, second degree type 2, we will have the same effect, but without the prolongation from cycle to cycle. So the interval between P and P wave will be constant, and then you will have a place where it stops firing at one stage, okay? So it fires, and then it doesn't. And this happens constantly, okay? So everybody understands the term of Weichenbach periodicity and the difference between type 1 and type 2 of second degree?
Yes.
Okay, thank you, Martha. Now, the third degree is a type of a tricky question, okay? Because we talked about what happens when we have a sick sinus syndrome. We talked about apnoid pauses, and as you understand, the conduction system would not leave the heart to it. They will have a junctional rhythm to take over the firing to keep the heart working, okay? So this will lead to an atrioventricular junctional rhythm, and yeah, it's true. We did see this. It is the superior, middle, and lower nodal rhythm, and this is how it will appear on the ECG. Superior nodal rhythm, we talked about the rhythm of the coronary sinus with negative P waves before a QRS. Middle nodal rhythm with no presence of a P wave because it is hidden inside the QRS, and a lower nodal rhythm where the P wave is negative and found after one QRS. Do you remember this, guys? Do you remember the shape where we showed the negative P wave after the QRS. This is the one, okay? This is a state exam ECG, lower nodal rhythm with negative P wave after a QRS, okay, Philippa? Good. Now, take home messages, sinoatrial node block, 3 degrees, first degree with no ECG changes, but it is true that it passes to second degree or third degree. Second degree, we have a P wave and a QRS go missing, even with or without Weichenbach phenomena. So Weichenbach phenomena, periodicity, it happens after a specific amount of P to P prolongation or with a constant P to P interval in type 2 and no Weichenbach phenomena, okay? Keep in mind, junctional rhythm, superior, middle, and lower nodal rhythm in relation with the P wave to the QRS, okay? And I hope, but now you can see that everything starts to stick together, and this is why the first lecture was important, because if you understand the first part, now you don't have to study anything else. It just makes sense, okay? Now, atrioventricular blocks, this is very important because it's very common, okay? And the impulse conduction system between the atria and the ventricles is very vulnerable. So we will take a look at the PR interval, okay, which normally is between 0.12 to 0.2 seconds. Again, 3 degrees, okay? The first degree AV block, we will have a constant but prolonged PR interval, more than 0.2 seconds, okay? And this is because there's some kind of conduction delay, but nothing severe. It's asymptomatic, and there isn't such a big problem. Can everyone see the prolonged PR interval, or do they want me to explain how to see it? Do you all understand the concept of prolonged PR interval and how it appears on the ECG here?
Yes.
Okay, so this is second degree. I hope you didn't think it was going to be too easy. So, second degree AV block, we will separate it again based on the presence of Weichenbach's period and Weichenbach phenomena, which means the same thing, into Mobitz 1 and Mobitz 2. Okay, would someone care to address what they think the presentation of Weichenbach periods will be in the second degree AV block? So,
prolongation of PR interval?
Yeah, until when? Until, again, a P wave sends no message to a QRS. So before, there was a problem with the sinus, and there was no P wave and no QRS, okay? Exactly, Jan, exactly. There will be a P wave that has no PR interval, and this is how, there will be a P wave with prolonged PR interval and no QRS, okay? And I need you to pay close attention to this rule, that the amount of P waves will be n plus 1 divided by the number of QRS complexes, which will be n. And this is important because I know for a fact that in the pathophysiology exam and the exam of internal propedeutics, you will have to reproduce this formula, okay? So what does it mean? We said that the general rule is n to 1 to n, okay? So here you have 1 P wave, 2 P waves, 3 P waves, 4 P waves, okay? But 1, 2, 3 QRSs. So does anyone want to write how this formula will be in this case? Can someone write in the chat how this formula will be? It's P to QRS. As you can see here, the P wave has no corresponding QRS. There is a pause and then the cycle starts again. So Mobitz 1 will be n plus 1 to n. Can someone let me know how we will express this? Yes, exactly. It's 4 to 3, and this will be constant, all right? Again, 1, 2, 3, 4, but only 3 QRSs and 1 is not present, okay? So I take it you all understand how this works. Mobitz 2, again, will have a prolongation of the P, actually we have an absence of a P wave. We'll have a presence of a P wave and an absence of a QRS. So you can see, one is here, but there is no QRS. 1, 2, 3. And again, the difference between MUDr 1 and MUDr 2 will be the expression of it mathematically. So there will be 1, 2 P waves without one QRS, okay? 1, 2, 3 P waves without one QRS, okay? Can someone explain to me at this part of the strip, the part where I will draw now, what the ratio will be here? Can someone tell me the ratio here? It's MUDr AV block type 2, MUDr 2. Can someone write to me in the comments? What will be the ratio here based on this mathematical formula here? Yes, yes. So Ishak, you have the hang of it. It is 3 to 1. Why? Because there is 3 P waves before a QRS goes missing, okay? Good. So let's proceed. Again, another example. This is type 1. Can someone go through with me and explain to me why it is type 1 AV block? Open your mics. Guys, anyone?
We have
Because-
prolongation of the PR.
Okay, let's go to the top one, okay? The PR interval, it is prolonged, okay?
So based on that, we can understand that it is a kind of MUDr 1.
Mm-hmm. What else is missing to make you think that it is an AV block and not an SA block?
It's the QRS complex.
It's missing right here, correct. And would you care to tell me how the formula would look like in this case?
For this one, 4 to 3.
Yeah, precisely. Correct. It is 4 to 3. Yeah, great job. I don't know who you are, but great. You got the hang of it.
Mhm.
So, next part would be MUDr 2, okay? So MUDr 2 will present with a PR interval, which is longer but constant, and then you would have one missing. Would anybody care to tell me how this will form here? Anyone? Yes, 4 to 1 is the correct answer. Why? 1, 2, 3, 4, and 1 QRS missing, okay? 4 P waves and a QRS missing. Excellent. Now, this is very important for 6-year students. Third degree AV block or complete block occurs when the ventricles and the atria contract independently of each other and at complete random, okay? So they fire completely wrong and the blood does not fill the cavities of the heart properly. The heart cannot function as a pump properly in third degree AV block. And it's very important to reverse this before the patient dies, okay? And now you will ask me, how do we diagnose this? But it's simple. If you think about it, since they fire independently at stable intervals, the distance from one P to another will be the same, even though it's not connected to the QRS after it, and the QRS to QRS distance will be completely the same, but not at the same rate. Do you understand what I'm saying? I know it sounds weird,
Yes.
but if you think about it, this is a QRS, okay? And this is a QRS. And this is a QRS. And this is a QRS. The distance between all those will be constant in third degree AV block. And at the same time, this is a P wave. This is a P wave. This is a P wave, and the red parts are always equal between each other, while the green parts are always equal between each other. So if you have those two being equal, you know, from QRS to QRS and from P wave to P wave, you have the ventricles firing and automatically, the atria firing automatically. So that means you have a third degree AV block. Do you understand this? This was hard to see for me as a student. It was tough for me to understand, and this is why I'm trying to explain this a bit more thoroughly. Do you guys get it? Good. Goody, goody. Okay, so take home messages. Oh my, skip this. I meant AV node. Okay, so first degree AV block, prolonged PR interval. Second degree, Mobitz 1 or Mobitz 2 with periodicity. And third degree is when the atria and the ventricles fire independently. So the P to P interval is constant and the QRS to QRS interval is also constant. Any questions? Good. So, block of Tavara bundled branches. I take it no one said Tavara during anatomy, but yeah, the right and left bundled branches are called branches of Tavara, okay? And they're found in the ventricles. So, will anyone care to tell me what the problem will be on an ECG since there's a problem in the ventricles? Just say it. Don't be shy. I don't bite. Which part of the ECG wave will have a problem? No,
In the QRS.
Yeah, in the QRS, exactly. And it's usually due to anatomical abnormalities. Okay. Good. So we will separate them into right and left bundle branch blocks. And V1 and V6 leads will be your best friends for this. Okay. As you can see here, there is very specific morphology of the QRS. Do you see it here? This will be an R, S, R pattern, while here and here in the left bundle branch, the morphology will be entirely different. This is a very specific wave, and this is indicative of a right bundle branch block. Okay, so V1, if you see this in V1, V2, and V3, you will be aware that we are talking about a right bundle branch block. Okay. Meanwhile, looking at a left bundle branch blocks, you will see a deep Q wave in V1, while a broad and clumsy R wave, which has two tops in V5 and V6. Does everybody follow? Right? Yes, everyone follows. Good. The thing is that, as we said, if this was an extrasystole, a ventricular extrasystole, can someone tell me, would it be from the right ventricle or from the left ventricle? Where would the extrasystole originate?
From the left.
From the left, even though it has a right bundle branch morphology. Excellent. And the opposite, of course, would be for the left bundle branch block, because with this morphology, this one actually in V5 and V6, we will talk about problems from the right ventricle. Good. It's true we are almost done. The toughest part of today's lecture was done, and I think it was relatively fast. And I think if you don't mind, we can take a 5-minute break before proceeding with coronary syndrome and Ecg, and of course, inflammatory and metabolic abnormalities and how they appear on Ecg. Is everyone okay with a 5-minute break? Yeah, good.
Yes.
See you guys soon. Guys, so do we carry on? Is everyone here?
Yes.
Okie dokie. So let's go. Coronary syndrome and Ecg. So what is an acute coronary syndrome? Acute coronary syndrome is the presence of decreased blood flow in the coronary arteries that supply the heart muscle. And since there is low blood supply to the coronary arteries, there is low blood supply to the cardiac muscle. Now, this will appear as centrally located chest pain, which is crushing and heavy, and it will radiate to the left shoulder, the angle of the jaw, and it's associated with nausea and sweating. Okay, I want you to keep this picture in mind to see the STEMI and not STEMI. As you can see, the STEMI is a proper occlusion of the entirety of the vessel, while non-STEMI is an intermediate form and it's occlusive at a lot more places, but it allows always a passage open. Okay. So what happens when there's no blood supply? Of course, infarct zones develop, and there are three of them. Okay, in the center, we have the zone of infarction, the zone of necrosis, which is in the center, and it can be subendocardial, which means that it doesn't involve the whole thickness of the cardiac wall, or there is full wall thickness, and it's something that we call a transmural. This will present as a STEMI MI. Okay, then we have on the outer part, the zone of the lesion, which is actually still supplied with blood, but it's slowly about to die, and the zone of ischemia, which is the outer part, and it will be the first one to recover if we fix the blood flow that is not going properly to that place. Now, let's talk about ST elevation ECG. This is also known as STEMI. STEMI is an indicator of an acute myocardial infarction with myocardial injury. And if this happens, we know that there is a real big problem, okay? It is transmural, so it involves the thickness of the whole wall of the heart. And this is what I'd like you to see. This is a very important slide. The STEMI MI is actually an active process, so it changes during time. Okay, we start from here where it's normal, and here you have the start of the MI. As you can see here, we have hyperacute T waves at the start, which are wide and tall, and these are followed by an ST elevation. Can anyone from the audience of the older years tell me the name of this wave right here? Anyone? Speak up. What is the name of the ST elevation of the wave? Yes, Jan, it is. This is the famous party wave. And this is very important for you to know and stress it because it's an indicator of an active MI. Sorry. So this is a party wave, correct? Good. As you can see, as time passes by, there is again a difference in the morphology of the MI and how it presents. As you can see, the T wave morphology changes and it becomes inverted, even though here it was way high up along with the ST. And this is where we pass to the subacute stage of the MI, where the ST elevation has improved drastically. You can see it's nearly flat. The T wave is opposite. And here at the end, you have the presence of pathological Q waves, which means that the myocardium is actually dead. The presence of a pathological Q wave is actually like a stamp. It always lets the doctor know that the patient has gone through a STEMI MI. Okay, guys, so does everyone understand how this will evolve during time? So the T wave will get bigger, and then we will have an ST elevation with the presence of a party wave, but then the T wave will invert. We pass to the subacute phase. We have ST elevation actually improving and becoming less high. And we finish with a normal T wave, but with the presence of a pathological Q wave. And we will talk about the pathological Q wave because it's very important to understand. As we said, party wave, especially present in ST elevation, okay? Now, can anyone go through with me here? And let's talk about the ST elevation. Don't be shy, I don't bite.
So we have an ST elevation in leads 1, AVL, and yeah, I think that's it. So it should be a lateral
Not only,
contraction.
we'll talk about where it is, but where do you see the other part? You need a STEMI in 2 consecutive leads with a contralateral depression in order to characterize it as a true STEMI. Okay.
Okay.
So
we have
if we talk about,
yeah, we have a ST depression in lead 3 and in lead 2 and also in
okay. Okay. So you're correct. Okay. So the presence of all of those is necessary, and we will talk about why, because this is how we will differentiate it STEMI with pericarditis. Okay. So you need ST elevation and contralateral ST depression present, okay, in order to diagnose a STEMI. Now, you will ask me, but we spoke about Q waves as part of QRS, isn't that normal? And yes, they are. But when we talk about the presence of Q wave in STEMI and MI, we are talking about a pathological type of Q wave, the Q wave that lets us know that the patient has been through an MI. Keep this in mind, that the presence is a sign that irreversible myocardial cell death has occurred, and they appear within hours. Why do they form? Because if the myocardium is dead, the conduction and the electricity cannot pass inside it, because how will it pass? The cells are dead. So it has to find another way, another route to pass and conduct the signal to the remaining alive cells under the infarction. Okay. So that's why it forms a pathological Q wave. What are the criteria? It needs to be less than 2 tiny boxes, so more than 0.04 seconds. And the depth of the Q wave has to be more than 25% of the R wave that belongs to the same QRS complex. Okay. And it has to be present in 2 or more continuous leads. So with this in mind, more than 0.04 seconds, it has to be at least 25% of the R wave of the same QRS, and it has to be in 2 leads. In this example here, there are 2 leads with pathological Q waves. Can someone tell me which ones they are? Please take up the mic. And don't hurry up, because it is kind of a trick question. Anyone?
AVR and AVF.
So AVF is correct. AVR, no, but why not?
Because I think because normally in AVR we have the inversion of the waves, so
yes,
that's kind of normal. So I think
we said the 10 rules of ECG on Monday. In the AVR, the Q wave can actually be negative. So AVF is the 1 lead, yes. Which one is the other lead? Is it 1 or V2? There's a 50% chance you'll get it right, so no biggie.
it's 1.
Yes, it is 1. It is 1. And can you tell me why it isn't V2?
Because in V2, in V2 it's not the passing the borderline, which is 25%, and it's not more than 0.04 seconds.
Yes, but there's something else as well. If you pay close attention, this is the Q wave of the QRS in the QRS complex, not this one. This is the S wave. Do you see it? Who did I talk to?
It was me. It was me.
You see, the first negative deflection after the P wave is the Q wave. The second one will be the S. Okay, it is a trick question, but you can actually get this. Okay, everything in accordance with this? Does anyone disagree? Okay, so I think not a problem. Is everyone clear with STEMI myocardial infarction? Are there any questions? Speak now or forever hold your peace. or until at least we do the Q&A session next week, probably. Okay, so non-STEMI myocardial infarction. This is actually a more common version of an MI that occurs in real life, and it doesn't involve the thickness of the whole wall. So this is subendocardial, and it's related to thrombosis of a major coronary artery, either right or left, okay? And this will present it differently with inversion of the T wave and depression of the ST segment. So I think it's pretty straightforward. Let's go through it, shall we? So the blue arrows indicate ST depression, and I really hope you can see it by now. We said that the ST should be flat and heading upwards towards the T wave. And as you can see in lead 1, AVL, V4, V5, and V6, it is depressed, it's going downward. And at the same time, where the pink arrows are pointing, you can see those are actually negative T waves. So the presence of those two combined are a sign of non-STEMI MI. And that's it. It is pretty simple. Does everyone understand this? I know it is a lot, but we will go through examples at a separate lecture and try to take it all in and explain it again and again, because revision will make it perfect. Okay? Does everyone understand non-STEMI MI? Excellent. Now, I think it was Bruggada said before that, yeah, it is anterior lateral wall that has infarction. This is the most important slide of today's lecture. This is the way to be able to categorize the origin of the MI, okay? So it can either be laterally, inferiorly, or anteriorly. I need your attention. Do not ever say the word posterior on a 12-lead ECG. It is impossible to see a 12 lead ECG showing a posterior MI. A posterior MI requires the presence of a 15-lead ECG where you have extra leads and electrodes on the back of your thoracic cage. Okay, so let's talk about lateral leads for anterior and septal MI. Anterior and septal MI will require the presence of V1, V2, V3, and V4, and it will have a problem with the left anterior descending artery. Okay, now inferior MI will be on the bottom. How will we see that? Leads 2, 3, and AVF, and this will be probably a problem in the right coronary artery. Last but not least, we'll talk about lateral MI with problems in leads 1, AVL, and V5 to V6 with problems in the left coronary artery or diagonals of the LAD, such as the marginal artery or the circumflex. Is this clear? I need you to understand this shape because even if you don't remember the leads per se, if you have a photographic memory, you will remember that anterior and septal will be on the precordial leads, lateral part will be on lead number 1, as well as the V5 and V6, and 2, 3, and AVF will be part of the inferior wall of the heart. This is relative to the views of the heart that we showed with the guy in the pictures with the vectors in the basics of the ECG lecture, okay? Does anybody have any questions that they would like me to explain concerning this slide? Good. I beg of you, never say the word posterior on a 12-lead ECG. It's just plain wrong, okay? Now, take-home messages to finish the second to last part of today's lecture, okay? MI can present as STEMI or non-STEMI, and based on the morphology, we can guess the age of the event. So we will talk about the party wave and the inversion of the T wave and the presence of ST elevation. Keep in mind that STEMI MIs will present as Q or non-Q pathological waves, and never forget how non-STEMI will have the inversion of the T wave and the ST depression, okay? And this is it. We're making it into the final part. Does anybody have any question about the MIs in the ECG? I hope it was pretty clear. It is straightforward, okay? Now, part 6 will be extras, and this is especially for the colleagues that are in the last years of the med school. Now, pulmonary embolism, we all know what it is. It's a presentation that occurs due to a blood vessel in the lungs, okay? And this has the very specific formation of S1, QT, and T3. This is the acronym, where we have a large S wave in lead 1, a presence of a Q wave that is big in lead 3, and an inverted T wave in lead 3. This is actually important to know as an idea, but it's very rare that you will see pulmonary embolism presenting on an ECG. Okay, this will be condition number 1. Condition number 2 is pericarditis, and I hope you were following when I said that in STEMI, you need contralateral depression of the ST segment. And this is why, because here, if you accept AVR, where it was correctly said that you can have negative waves, ST elevation can occur in every single other lead. And this is very important to make you think of pericarditis and not only STEMI. Okay, do you get this? Does everyone understand this? Philippa, is this okay as an idea? Good. Now, let's talk about tamponade. Tamponade is a condition where there is a fluid inside the heart, inside the capsule that surrounds the heart. And that doesn't allow the heart to contract completely, okay? And now you will tell me, why do I care? You care because this leads to a cardiogenic shock and the patient dies, okay? And this will present how? This will present with a low voltage QRS. And this actually makes sense why it presents with a low voltage QRS. It presents with a low voltage QRS because the fluid doesn't allow proper conduction of the signal to the skin of the patient, where we actually have the electrodes, and we will have something that is actually called electrical alternance. And you can see this here. In electrical alternance, you can see that every QRS is of a different height. In the other ones, they more or less look the same. But as you can see here, the height of the QRS is different. Why? Because with every beat, the fluid is at a different place, and the QRS translates into that entirely differently, okay? Does this make sense? Okay, you can see the pulse alternance here. Good. We're nearly done, guys. So, last but not least, electrolyte abnormalities. There are two parts I want to focus on because this is what you're mostly asked and what you will look in clinical practice, and that's potassium and calcium. And that will either be hypokalemia or hyperkalemia, and hypocalcemia or hypocalcemia, okay? And the parts of the ECG that are mostly affected are the ST segment, the T wave, and the QT interval. Okay, so let's go through this one by one. Now, potassium abnormalities. Can anyone tell me the amount of potassium that we have in blood? You know, when you look at blood work, what is the amount of potassium you want to see? What is the range? It's like biochemistry, properties of internal. Anyone? Yeah. Both of you are, all three of you are correct, okay? So Philippa was bang on, 3.5 to 5.5, okay? And less than around 2.8, you will start to present with ST depression and a shallow T wave, okay? Those are the two parts I want you to focus. Prominent T wave, if you know that and you can see it, cool, good for you. I think it's quite hard. And hyperkalemia, especially above 6 millimoles per liter, actually 6.5, you can see the difference with the tall peaked T wave, a wide QRS, and a depressed ST segment. And if you think about it, it makes sense, because if hypokalemia does an ST depression and the T wave is shallow, in hyperkalemia, the opposite will occur. There will be a tall and peaked T wave and a wider QRS. Okay, you need to memorize this as is. The T wave is the part that we will take a focus on, along with the ST depression during potassium abnormalities. Okay, now calcium abnormalities, and this is a tad more important. We will talk about hypocalcemia, where we have a prolongation of the ST segment and prolongation of the QT interval. Now, the ST segment lengthening, we all can see, we know why, because it's after the QRS until the T wave, excellent. But what is most important clinically is the presence of the QT prolongation, because we said that it does the polymorphic ventricular tachycardia, also known as torsade de pointes. Okay, and this is very important for the life of the patient because they die. So if hypocalcemia does a prolongation of the QT interval and a prolongation of the ST segment, it's only fair that hypercalcemia will do the opposite. I think it's pretty self-explanatory then. Hypercalcemia, short ST segment and short QT interval. Is everyone okay with those? T wave and ST are the ways to go, okay? Excellent. So if there are no more questions, this will be the end of our primary go-through, basic ECG and basic conditions and MIs and blocks and atrial and ventricular problems. I'd like to thank you for sticking around. 38 people is a lot. I never thought it would be this many. It was a real pleasure to talk with you. I would really like your feedback, so fill in the questionnaire with the link that Mary will provide in the chat. And let me know via the survey if you would like to do a session where we do examples, and if you have any questions after re-seeing this on your own, we can go through it and answer any questions you have, as long as I'm able to answer it. Okay, it's been a real pleasure. If you have any questions, please feel free to let me know now before we hang up. And then the rest we will do on a later date, probably sometime next week. Okay?
I have a question, if it is possible.
Okay, hit me.
How can we tell the difference between the, what was it, ventricular tachycardia and the ventricular flutter? Because it...
Give me a second. Okay, you said ventricular flutter. So.
And ventricular tachycardia.
You see, the ventricular flutter has this characteristic sinusoid-like shape. It's always like this. Okay, always. Do you see it?
Yeah, yeah.
Do you get it? Good. The other one you want is ventricular tachycardia. The tachycardia, do you mean monomorphic or polymorphic?
Monomorphic.
Monomorphic, you actually see the wide and aberrant QRS that looks exactly the same with every single beat. Plus, you will know it's a tachycardia because those are actually extrasystoles. They have the morphology of right or left bundle branch block. If you look at the flutter, you see this is not present. They're linear, they're sigmoid-like. Do you see sinusoid-like? Do you see it? This is the primary difference. The morphology of the QRS will be different. They both fire at a very fast pace, but the morphology is actually completely different.
Okay, yeah.
Does this cover you?
Yeah, yeah.
Does anybody have any other question? It's
Yes.
a good time to ask now.
Yes, concerning this one, is the ventricular flutter in the broader sense also a ventricular tachycardia? Can we call it like that? because it's also tachycard and concerning the ventricle?
Actually, I don't think you would have to differentiate during an exam, but it's good to know the entities as separate. Because if you look, they have some basic differences. The rate, a tachycardia can be at 130 beats per minute. A flutter is more around 200. So actually, if I were you, and what I still do is, if it's less than 180, I talk about tachycardia, and I talk about flutter if it's around 200, okay?
Okay, thank you.
You're welcome. Anyone else? Okay, please don't forget to fill in the questionnaire. If you have any questions, tell Jojo and she'll transfer and we'll go through them one by one at a later date. It's been a pleasure and thank you. Joe, do you want to say anything?
Bye.
Bye.
Thank you.
Thank you, goodbye.
Bye.
Bye. Thank you.
You're welcome. Bye-bye.
Sotiri, μου, can I ask you something?
Πες μου, Μαρθελίνη μου.
How hypokalemia converts into torsade de pointes?
Το πώς κάνει convert δεν το καταλαβαίνουμε. Wait, let me say it in English. How it converts, we don't completely get it yet, but we think it gradually prolongates the QT interval. Okay, constant prolongation of the QT interval will lead to complete problematic conduction in the atria, leading to torsade de pointes, because they start firing at random because of the long QT. And keep in mind, this is important because the treatment is actually magnesium. Σε κάλυψα.
And the connection between magnesium and potassium?
This is in an intracellular level.
Okay.
Keeps the potassium inside the cells.
And does this also somehow make the conduction in the ventricles completely aberrant? Because
Yes.
the point looks I don't know.
Completely aberrant.
Yes, exactly.
Yeah. Yeah.
Okay. Thanks.
It's very important to have magnesium during first aid because of this reasoning. Because you need to provide it in case of torsade de pointes.
Makes sense.
That's it.
Thank you, Sotiri. Thank you.
You're welcome. You're welcome, Martha. You're welcome, Mrs. President.
Thank you, guys.